And good afternoon, America. Live coast to coast via internet, I am Dr. Randy Fink from CNY Fertility in Colorado Springs. And I am also the medical director at the Miami Center of Excellence, CNY Fertility at the Miami Center of Excellence in South Florida. Good afternoon to everybody. Well, we've got a little kind of funny business going on here. We've got, normally we're on two different Instagram feeds, but for some reason, my own Instagram wouldn't let me do a live today. So we've got CNY's Instagram here. We've got CNY's Facebook and YouTube and LinkedIn, my own LinkedIn on here. Hi, Haley. Nice to see you and everybody joining us on the Instagram side. Good to see everybody. And of course, I would love to say hi to all, but the first person who joined me here, Pink Cashmere 1981. That is a fantastic name. So you get the gold star for that name. And we've got Hints Then, Making Baby McCree. We've got a bunch of others. August Queen. Ali Cardoza. Hi, Chelsea Loran. What else we have? Serge, we've got there. And the list goes on and on. Oh, I have to say that. Sea Beauty, Too Cutie. I like the name. Shelby, glad to have you. And hi to ACOM. And happy Tuesday to you. And Salustio 2021. So Miss Y Gracie is asking, I just had my second ultrasound today and the follicles aren't growing. When do you decide to cancel a cycle? Well, that is a very frustrating thing, but sometimes by that second ultrasound, we're not seeing a whole lot of activity happening yet. And so certainly if the hormone levels aren't going up, we would want to give that some cause for consideration. And probably by the time you do a next ultrasound, if we're not seeing any growth, we don't necessarily automatically cancel the cycle, but we might look to see, well, do we need to change over? Do we need to increase your dose? And let's see what's happening with that. It's been kind of a frustrating week, here in my world, and we all have our frustrations. As I said last week, there was something that crossed my desk that was particularly meaningful, and that was that with every shadow is caused by a light. So there is always a light there someplace if you just know how to look for it. And I admit that sometimes it gets really hard to know how to look for that light, especially when you're riding the fertility roller coaster. The important thing I want you all to know is that you're not riding that roller coaster alone. We are here with you, the entire CNY staff and family and all of our patients out there. This is an extraordinarily supportive group. The CNY user groups, the support groups for each of our offices, and I believe there's one nationally as well. Even on here, folks have really just a very unique knack of being able to know exactly what you're going through, what you've been through, and hopefully the bright futures still to come. So please use those resources. Use us. We love to be here for you and love to look forward to all the beautiful pictures and all the happy stories still to come. Hi, Damari. Nice to see you on the Facebook side. Haley has given me some bad news here. My first transfer was not successful. The estrogen was 678. Progesterone was pretty good. What could you have done differently? Well, to be honest with you, it's an important consideration that just because it doesn't work doesn't mean that there's something that's wrong. So with IVF, and I know, Haley, you had a really high quality embryo, a 4AA, and yes, that's a good thing. But to be honest with you, as we always tell folks, embryo grade really doesn't count so much. It's a beauty contest, so we can have a very gorgeous embryo that turns out to have complex chromosomal abnormalities, and we can have a poorly graded embryo, or what you might call an ugly embryo that is the only normal one in the bunch. And so don't stick too much with that. And most importantly, don't lose hope there, Haley, because an untested blast, and a blastocyst is, of course, an embryo that grows to day 5, day 6, or sometimes even day 7. An untested embryo gives us about a 30% chance of pregnancy per cycle. 30%. And you may say, oh my God, it's only 30%. Well, if we test the embryo, if we've done PGT testing, we know that that embryo may give us up to a 60% chance of pregnancy. And that's the very best that we can do with IVF. So an untested embryo is about a 30% chance. And you say, is that it? Is that all I get out of this? Well, compared to home intercourse, if you're having intercourse at home and there's no issues like a fallopian tubes being blocked or a sperm issue, home intercourse gives you anywhere from probably a 1 to 2% chance of a pregnancy per cycle. And a cycle may be, your menstrual cycle, that one whole month, 1 to 2%. So it's not very high. And so when we talk about 30% chance per embryo, it's an order of magnitude higher a probability of being pregnant, but it's still not 100%. So if you've got other embryos, I would say let's look forward to one of those being successful, because Haley, I'm sure they will. Is it worth it to thaw, biopsy, and refreeze? The biopsy would be PGT testing. For you, Haley, I wouldn't necessarily recommend that because you are a young person. So the odds are that you are going to have a normal egg to make a normal embryo. But just like we don't get pregnant every time we have sex, every egg is not going to be normal. So the fact that you grew something out to a blast and it was a highly graded blast tells me, well, you know what? The physics are working. We just need to get the right embryo. So don't give up hope, because I do think the next time is going to work for you. So fingers crossed. What else? We've got some more questions here on the Facebook side. Shay is here and says, I can't wait to start the journey with CNY. Tiffany's asking, how does DHEA help in the fertility and IVF process? So DHEA is a supplement that specifically is useful for folks with diminished ovarian reserve. It's on our evidence-based supplement list. DHEA, 25 milligrams 3 times a day is the recommended dose. Basically, DHEA is part of the hormonal cascade that ultimately is metabolized to testosterone, and testosterone is ultimately metabolized into estrogen. So in the case of folks with diminished ovarian reserve, the more we can estrogenize those eggs within the ovary, the better off we'll do. Now, that is not something that I would use across the board. If you don't have diminished ovarian reserve, I would not recommend DHEA. And certainly if you have polycystic ovarian syndrome, I would not recommend DHEA. So, but that's how that works. Grace Young, nice to see you, Grace. I have only one fallopian tube due to an ectopic. Would an IUI be okay, or should I just go to IVF? Well, in general, we say that folks with one fallopian tube typically have pretty close to the same fertility as somebody who has 2 fallopian tubes. An IUI is certainly an option. So I generally quote that an IUI will provide you about a 5 to a 9% chance of a pregnancy per cycle. And again, a cycle is that entire menstrual cycle. So 5 to 9%. Compare it to IVF, which with a tested embryo can give you up to a 60% probability per embryo. So the fastest path to pregnancy and the most reliable path to pregnancy is with IVF, but it's the most expensive, And it's also the most invasive. It's intrusive to have to do all this monitoring and have to come someplace for a retrieval and everything that happens in the laboratory. So if an IUI works, then it's fantastic. Then you're a hero. Then you did, you got pregnant without having to, resort to IVF. So an IUI is definitely an option, and potentially it's an option for many people. However, govern yourself with that. Sometimes what happens is that I'll talk to someone for a consultation and we'll set them up for an IUI because that's what they want to do. And then they come across my desk again for a consultation, 9 or 10 months later, and they've done, 8 additional cycles of IUI. And I would say, don't do that. I'd say try it a few times. And if it doesn't work, then step up to something else. So Grace, that one missing tube should not have too major an impact on you. Let's see who else we have here on the Instagram side. And Amber's here. Hi, Amber. Yeah, my Instagram just, it wouldn't work. And, and I don't know why. I don't understand. We updated the app and everything else, but you press the button to go for, to do the live, and it wouldn't give me the option for the live. So instead of using the iPad, I'm on the phone here and just on CNY's side because more people look at CNY than they do me, although I don't understand why. We have a good time here with our Instagram. If you haven't seen some of those videos on my Instagram page, please take a look because like I say, we try to keep it light, try to keep it educational, and try to have a good time. Jasmine is with us on Instagram. Hi, Jasmine. I am scared that I may be having a chemical pregnancy. I won't know until tomorrow when I do the second beta. If that's the case, what should I do next? So a biochemical pregnancy sounds so mysterious, doesn't it? It sounds very highly technical. Biochemical pregnancy just means that the pregnancy test turned positive and that whole ball started rolling, the cascade started moving that direction. But then the body realized, well, wait a minute, there's a problem here with the embryo. And so the number starts to go back down. And that typically, by definition, that's happening before we know that it is a clinical pregnancy, which would be the point at which you could see it inside the uterus. And that's usually not until after 6 weeks or so. But a clinical intrauterine pregnancy, we can typically diagnose a little bit earlier based on what's called a gestational sac or a yolk sac in the uterus. The biochemical pregnancy is really just the marker of the positive pregnancy test without having anything to see by ultrasound. And that is almost always a chromosomal problem. That happens because of a genetic issue that's not going to allow that embryo to continue to grow. And guess what? It sucks because it's like a tease. It's a torment. It's like, look what I have for you, but you can't have it. It can honestly really be, pretty traumatizing when that happens. But what it says to me is not that it's something terrible. While yes, I certainly would have wished that you had a normal pregnancy, but in fact, what it tells me is that everything worked. It tells me that the brain is talking to the uterus. It tells me that the hormones were doing what they were supposed to do. It's telling me that uterine receptivity is where it was supposed to be. So that embryo implanted, it tried to take up shop. However, there was a problem with the embryo itself. So what that says to me is that it really can prove that the mom part is working, that it's still the embryo. So Jasmine, I hope, for heaven's sake, we certainly all hope that we will see this to be a real pregnancy, an ongoing pregnancy for you. But if it is a biochemical, then let's all know together that this isn't you. This was an embryo problem. It's a half a step in the right direction. So good deal there. Hi, see me, Victoria. And hi to Lil Red. It's me, Callie, says, do you recommend waiting any amount of time after one failed transfer before starting another? It's a common question, but in reality, there's no data that tells us that going sequentially from transfer to transfer is not okay. You have a period, and when you have that period, it cleans everything out. It's rebooting the system. And when you reboot, then you're able to start again. So the more important question there, Callie, is when are you both emotionally ready, financially ready, logistically ready? But from a timing standpoint, when folks would have a miscarriage, and we would talk about it. We used to tell people, well, we want you to wait for 3 months before you try to get pregnant again. Well, nowadays, the data shows us that's really not true. As long as you have that first normal period, then there is no detriment to the pregnancy itself. If you do conceive before you get that first normal period, there is an increased risk of another pregnancy loss. However, in this situation, after an unsuccessful transfer, and let's call it unsuccessful more than failed, because failed means that there's some judgment there, and it's just simply the fact that it didn't work. That doesn't mean, again, it doesn't mean something's wrong. It just means it's not a 100% transaction. So the fact that it didn't work just means that we're going to try again, and you can go the very next month there. Hi, Brandis. Brandis has joined us today on CNY's Instagram. Best advice for PCOS and low sperm morphology. This looks like Manji, I think, going into IUI next month. So for folks with polycystic ovarian syndrome, I generally recommend either that you be on metformin, or that you use the supplement known as inositol or myoinositol. They really do the same things. And what they do is that they can increase the pregnancy rate, they can decrease the miscarriage rate, and then once you are pregnant, can decrease the risk of certain pregnancy complications ongoing, specifically gestational diabetes. As far as morphology goes, morphology is what sperm look like. So maybe I haven't realized it, but sperm have a head, they have a neck, they have a tail. And our andrology folks can sit and look in the microscope and actually tell us what they're seeing. Somebody actually kind of gets a degree in looking at sperm under the microscope. Sounds fascinating, doesn't it? Well, it is actually pretty cool to go in the lab and see all the sperm swimming around. I took a video in there last week. I think I have a couple of those on my Instagram of sperm swimming. Maybe I'll put that one up after I do this one, just because it's kind of neat to see them under the microscope. Morphology means that there is some decrease in what looks normal under the microscope. And did you realize that 96% abnormal sperm is what's considered normal? So having 4% normal morphologic forms, or what sperm look like, only 4% of them look normal, is normal. Now, some people will have an abnormal morphology where they have only 3% or 2%. Morphology is not a cause of infertility. It's something that we see associated with couples who are suffering with fertility problems. And so I wouldn't worry too much about that, but certainly in men who have a low morphology, we recommend, there are some male supplements that we recommend that all come from the book. It starts with the egg, and that is the quintessential guide to everything evidence-based as far as the biochemistry of supplements and what we can do with those supplements to aid in our fertility. It's 20 minutes after the hour, and you're here with Fertility with Fink and Friends. Thank you for being my friends today. It's good to see everybody. Let's take a look back at the Facebook and LinkedIn side. Damari says, if in my first retrieval I had all of my 3 embryos were abnormal, do you recommend that I do a PGT in my second retrieval or not? Well, that PGT question comes up a lot. PGT is really, and you know what, I think this is really an important consideration. Why do people use PGT? PGT is most useful for taking a large group of embryos and helping to select the group that has the highest probability of being able to get you pregnant. So again, a PGT tested normal embryo gives you about a 60% chance of a pregnancy. So that's a great thing. But if you're limited in the number of embryos, if you have 2 or 3 embryos, is it worth doing PGT testing? And Damari, what I would tell you is that obviously it's up to you to do what you feel is best. But let's say you had 2 embryos. You could put those 2 embryos back. You could transfer them into you, and your body is going to give you the same information. The embryos are either going to stick because they're normal, or they're not because they're not. So do you really need to pay for the biopsy? Do you really need to, 1, risk growing them to the blast stage where they may not? 2, pay for the biopsy. 3, pay for the PGT testing. 4, wait for those results to come back, when really, if you put that limited number of embryos back inside your uterus, they may have a chance to grow, whereas they may not have grown in the lab. And your uterus, your body, is going to give you the very same information as what the lab would give you for that PGT. Now, it's a different story. If you've got 10 embryos, geez, that's a lot of transfers to potentially have to do in order to get to the half of them, let's say, depends on your age, that may be normal. So that's when PGT, in my opinion, is useful. It helps us to select out the ones that are most likely to get you pregnant, and therefore you can do fewer transfers. CB Victoria was kind of just asking the same question on the Instagram side. I have 12 good embryos frozen, and I regret not testing now. Any thoughts on PGT? Well, you just heard my thoughts on PGT, but that's exactly the scenario that I think PGT is useful. You can still thaw embryos, biopsy, and refreeze, only to then thaw the ones that are normal later on. You do run some risk with that. Would I choose to do that with my own embryos? Well, I don't know. I haven't been in that same situation. So I would give it careful consideration, because it will help you to take those 12 embryos to know which are the ones most likely to get you pregnant. But you do run some risk from that embryo, from the freezing and thawing with those embryos. It looks like Ikra Ali, I think that says, had an egg retrieval yesterday and got only 3 eggs retrieved. My friend, don't lament 3 eggs. Now, it's true. IVF is a numbers game. We would like to, the more eggs, the more eggs you have, the more embryos you make, and the more options you have. But how many eggs does it take to make 1 embryo? 1. And how many embryos potentially does it take to give you 1 baby? Same number. It's 1. So don't discount what you got there. It's egg quality, not egg quantity. So my fingers will be crossed for you that those embryos will continue to grow, look beautiful, and will give you a baby. Now, that said, maybe you want to think about doing another retrieval. And what I always encourage people to do is that if they're able to do a back-to-back, or what we call a stacked cycle. So if we just did a retrieval yesterday, and here we are in May. So the meds that you used for stimulation in April and May will continue to help you to recruit eggs in your next cycle. So roughly 10 days or so after your retrieval, you're going to get a period. And when you do, you start your next stim again. That's a back-to-back cycle, or a stacked cycle. Strongly encouraged, because egg quality goes up and quantity of eggs typically increases there as well. So fingers crossed for you, my friend. We've got some more on the Facebook side there. Let's see. It looks like Amber Harris. Hi, Amber. Hello from the road back to Montana. Hope it's a safe drive. Looks like the weather outside today here is pretty beautiful. Oh my heavens, actually, according to my watch, it's 79 degrees here in Colorado Springs. And it was about 38, I think it was, this morning. So Mountain Spring. Here we are. Tiffany is with us. Do you recommend transferring 1 or 2 embryos for women 40 and older? So according to the ASRM guidelines, the American Society of Reproductive Medicine, in your 40s, transferring more than 1 embryo may be within the guidelines. People often say, well, I want to put back as many embryos as I can, as many as you'll let me, because I don't care if I have twins. I just want to have a baby, for crying out loud. Well, that's a risky business because we really don't want you to have multiples. Multiples will increase your risk, or rather increase your chance of having a positive pregnancy test, but it doesn't increase the chance of a live birth. Now, once you get to over 40, if they are untested embryos, then your chance of live birth may actually go up by putting in more than 1. So I think, Tiffany, it makes sense to consider doing more than 1 in that scenario. If they are tested embryos, if we know that this is a euploid normal embryo, absolutely not. I would 100% of the time generally recommend that you place back 1 embryo. But in an untested embryo, Tiffany, yes, 2 makes sense. Cassandra says, hi, Cassandra. I have PCOS and want to start trying for a baby in 2 years. What are some of the things I should do to prepare? Good question. So the first thing is folic acid. Folic acid is recommended for 3 months prior to conceiving because it decreases the risk of certain types of birth defects, specifically spinal birth defects. So folic acid, or really any prenatal, will have enough folic acid in it for you. So simply start on a prenatal vitamin. The other thing I would recommend with the PCOS there, Cassandra, is consider taking myoinositol. And I mentioned that again a few minutes ago when we were talking about metformin. Myoinositol is over the counter. You don't have to see your doctor for it. It is well tolerated. And what it does is that it helps to sensitize the body to insulin. And insulin resistance is one of the problems associated with polycystic ovarian syndrome. Insulin resistance. It means that your body is making insulin to try to metabolize your carbs, but you are resistant to that insulin. So it takes more and more of it. And so there is an association of being overweight with polycystic ovarian syndrome, of having some extra hair growth due to some of the hormonal situation, and having some particular lab abnormalities, some elevated androgen hormones, testosterone, and so forth, and a characteristic appearance on ultrasound. And that's the criteria for polycystic ovarian syndrome. Now, some people just have what we call polycystic ovaries and don't necessarily have that whole syndrome. You may be normal weight. In fact, there's even what we call lean PCO, where people are completely normal weight, but they just don't have regular periods. Inositol can definitely help you with that and help to kind of try to straighten out some of those metabolic abnormalities. So, Cassandra, that would be my best recommendation for starters here. Tori Beth is here with us and got a positive pregnancy test on the day 3 fresh transfer that Brandis did here in Colorado. Absolutely, 100% prayers to you. Congratulations, Mazel Tov, the whole 9 yards. And fingers doubly crossed. So let's see, back to the Instagram side here at 1:30, which means it's 6:30 for those of you on the East Coast, 3:30 on the West Coast. Thanks for spending your evening with me here. Thanks for being my friend on Fertility with Fink and Friends. M. Salustio says, last 2 retrievals, my estrogen levels were only between 500 and 600 at the time of trigger. Okay, that's fine. I read that the optimal levels are 218 milligrams per follicle. Not necessarily. So in the CNY system, a lot of folks will be using letrozole as a medication to help with their stimulation. I think, in my opinion, there is a place for letrozole, and some folks, Dr. Kiltz loves to use letrozole. So many of the folks who are following his lead directly, will put folks on letrozole. Letrozole lowers the estradiol level, so it's not specifically an estrogen level, my friend, that we look at there. That basically tells me, really, I consider a per follicle kind of number for estrogen about 150. So I know that, and really it's probably anywhere from 100 to 250. So that variability doesn't, I don't believe, means too much. It also depends some on how the stimulation was done, and on your age. So I don't think that that's necessarily a detriment or a problem, but what can you do to increase the quality of the eggs that are in those follicles? And that's really the ultimate question. The question is the issue of egg quality. Egg quality means, well, all right, so you're making a follicle. That follicle is lined by some cells called granulosa cells, and that's what makes your estrogen. And the egg is sitting inside. Well, the egg is actually hanging on to like a little stalk. And when we give you the trigger shot, wait, I have a visual here. When we give you the trigger shot, you like the visual? It tells the ovary, we're coming for you, eggs. So it lets go of the stalk, and the egg starts to float freely around in that fluid inside the follicle. Now, in nature, what happens is that then the ovary starts to work like a little squirt gun, and it goes, and it does make that noise, in fact. It squeezes that egg out of the ovary, and that's the function of ovulation. Some people, that is a painful experience. And you know what that's called? It's called Mittelschmerz. Mittelschmerz means painful ovulation. A lot of times people will ovulate. They will have an episode of Mittelschmerz, and they will say, ooh, something doesn't feel good. I'm going to the emergency room. And in the emergency room, they'll get an ultrasound or a CAT scan or something like that. CAT scan is not a great test to really be able to evaluate the pelvis, but it's done very commonly in the ER because you get a lot of bang for your buck. That you can see, if you do a CT scan of the entire abdomen, then you can see the gallbladder, and you can see the bowel, and you can see the ovaries and the fallopian tubes and the appendix. And but really, to evaluate the ovaries, ultrasound is a better test. But they may tell you in the emergency room, oh, you have a cyst. And you say, oh, no, I have a cyst. Ugh, I know people who've had cysts, and that's terrible. Well, every woman who has a period every month, who is releasing an egg, every woman has a cyst in the ovary every single month. And when you're ovulating that egg, you release that egg. That is 100% a physiologic normal cyst. It's a follicular cyst that then gets ovulated, and it becomes a corpus luteum cyst. And that corpus luteum is where your progesterone comes from. So that's where you make your estrogen. That's where you make your progesterone. But the egg itself, the egg quality, we can increase over about the 90 days prior to when that group of eggs is recruited to make follicles. So certainly if you're going to be doing IVF, as we in the sort of 3 months before, that's when we can really do some repair to the DNA that's in those eggs, because that's the window of opportunity. And that's what the supplement list is for. It comes from the book. It starts with the egg. If you'd like the list, let me know through my Instagram, Randy Fink MD, and I'm happy to send you that list. So let's see what else we have here. This comes from Brienne. Is a 1 centimeter septum something to worry about? So a septum is a little muscular band that is in the middle of the uterus. And if you have met my friend Uterus, here she is. She joins me sometimes, and so it's nice to have you. Thank you. A septum is inside the uterine cavity and is a little band that exists from here going down into the uterine cavity. The classic wisdom of a septum And this is something that's called a Mullerian anomaly. And it can go hand in hand with having a septum in the vagina, with having some kidney problems, and having an unusual shape in the uterus as well. So the classic wisdom was always that if we had a septum, we would like to remove the septum because it can be associated with recurrent pregnancy loss, that is miscarriages, that there seems to be some question about the endometrium, the uterine lining that may overlie that septum. Well, there was just a big published article that really saw no difference in the fertility outcomes of women having the septum removed and not having the septum removed. So the best current evidence, at least based on that large study, is that you really don't have to do anything about it. Now, it's a different story to me if you've had pregnancy losses. And if you've had recurrent pregnancy loss and you're known to have a septum, then 100% I would remove it. And quite frankly, the procedure that's done to remove a uterine septum is really very easy in the right hands. It's called a metroplasty. We're plasticizing your metro. A metroplasty means a septum removal. And really all you do is through a hysteroscope, through a scope, a camera that goes in the uterus, we have a little pair of scissors and we just go snip, 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 snip. And that little band goes, whoop. It doesn't make that noise, but it does go, and then it's gone. So it's a pretty straightforward thing to fix in most cases, especially a small septum like that 1 centimeter septum. We do it here in Colorado, not infrequently, even associated with a retrieval, with your egg retrieval. So it can really be done at the same time. Let's see here. So we've got a couple of other questions on the Facebook side. Oh, Heather says, my favorite guy at CNY Fertility. He's the best. Obviously, Heather is the smartest person I know. Let's go with that. I hope you and your beautiful husband are both doing well. Nice to see you, and thanks for being a part here. Celeste is with us, Celeste Connor, and Celeste says, I have stage 4 endometriosis, just off Orilissa and Lupron for 4 months and did a retrieval last Monday. Got 5 eggs, 2 of them degenerated, and 2 were not matured, and the 1 didn't fertilize. So my follicles were all measuring over 17 to 28. What could have gone so wrong? Well, I would tell you that, yeah, that is certainly a suboptimal outcome, Celeste, and I'm sure sorry to hear that you have had to go through that. So it's an issue of egg quality. The one thing I would say is, so we know that you have stage 4 endometriosis, which tells me that you've had a laparoscopy, that someone has looked inside and knows that it's there and you've tried to remove it. Endometriosis itself does affect does affect egg quality. And when we remove endometriosis from the ovary, it also does affect the AMH, the anti-Mullerian hormone, or our relative scale of ovarian reserve. So I usually personally reserve the endometriosis treatment for before transfer, because that's when I see it can really make the biggest difference. But with stage 4 endo, you had a lot of endo, and so I think it probably makes sense to try to suppress that, because as I said, endometriosis can affect the egg quality, but it sounds like the egg quality was affected there for sure, and that was likely the issue. What would I do for you? I would do, not knowing the rest of the story, but I would certainly think about the supplement list. I would think would be critically important, and probably some growth hormone, which is omnitrope. Human growth hormone has the ability to growth hormone is what keeps us young. So it has the ability potentially to help us to repair some of the age-damaged DNA, and some DNA that is keeping those eggs from being stable enough to be retrieved and to be fertilized. So that is certainly not the outcome we would have hoped for, Celeste. And I hope you're feeling better. At what point should an ERA be considered? An ERA is an endometrial receptivity assay. And to be honest, the current evidence shows us that the ERA may not be so useful anymore. It was predicated on this idea that we have a very narrow window during which we can implant a pregnancy. Well, it really seems like that window is much wider than we ever thought. So, I now reserve, an ERA was a standard part of the workup for me, even, as recently as 6 or 9 months ago, we would recommend an ERA in order to be able to know that the receptivity time of the lining is what we think it is, and that it falls into, in a medicated cycle, it's 120 hours plus or minus 3 of progesterone, or basically 6.5 days of your progesterone shots. And that's the reason to do it. But now I really reserve that test just for people who have had multiple failed euploid transfers, things that they really, really should have been pregnant. I do not consider it a mainstream part of testing anymore. Let's see. Hi, Sally from Trinidad. Nice to see you. Yep, July 1st is when Sarasota is slated to open. So that's very exciting. Karma is here with us, and Karma is asking, do any of the medication that's prescribed in the bundle package expire fast? I believe the HCG-LH does expire somewhat in a hurry, but I think that's the one that probably expires the quickest. And that's a very good question for our pharmacist friends. And maybe one day on Fink Friends, I'll see if I can get a pharmacist on here who can answer a bunch of questions for us. That's a really good idea, Karma. Thank you for that. I hope it's Maya, not Mia. Can you explain the reasons that make an HSG so painful? Oh, yes, an HSG is my least favorite thing to do to people because it is uncomfortable. But I tell you what can make the difference between torture and non-torture. It should probably be crampy, because we're placing a little straw inside the uterus and we're pushing some fluid in under relatively high pressure, which distends the uterus, and that makes you cramp. And we want that fluid to go through the fallopian tubes to show us that the tubes are open. But of course, there is also a therapeutic benefit to that. And that is that people have a tendency, an increased chance of getting pregnant in the month or two, probably in the 2 months after doing an HSG. So it does hurt. But what makes a huge difference is pre-medicating before doing the procedure. So I recommend 800 milligrams of ibuprofen. I do not recommend that you just take a Tylenol. I do not think that that will do anything. 800 milligrams of Tylenol. If you're having it in the morning, take that, not Tylenol, of ibuprofen. 800 milligrams of ibuprofen with breakfast if you're doing it in the morning. If you're doing it in the afternoon, 800 milligrams of ibuprofen with your lunch. That makes the difference between torture and just a cramp. So, but an HSG is a useful test. I do not order it typically in folks who I know are going to be doing IVF. There are some folks who do think that an HSG is necessary. HSG is, of course, a hysterosalpingogram. If you are going to do IVF and they're telling you you need an HSG, please ask why. In my opinion, I pass on it. Let's see here. Miss Gracie was hoping to see me next week for embryo retrieval. Yes, indeed. Well, I'll be here. What else do we have on the Instagram side? Kirsten with us today again. Nice to see you, my friend. I can't thank us enough for the support of the staff. And this is a great group who really wants nothing more than to see you pregnant. And I have to say, it's so nice to see all these familiar names here with me every Tuesday afternoon. It's great to see new names, but I really appreciate everybody being here. It's quarter till the hour. We'll be here for about another 15 minutes or so. Oh gosh, I didn't realize Amber Vince, my friend in Kentucky, is telling us that CNY Colorado Facebook page also offers mentors as well. There are a lot of people who want to help. And so please do avail yourself of that because I think it's fantastic. How long after a C-section? Making Baby McCree says, after a C-section, when can I transfer again? And what tests do I need before doing the next transfer? Well, after that C-section, generally speaking, I personally recommend that you wait a year. There's not great data on it, but the first thing that we know is that we want that uterus to be completely healed before there's another baby inside. And anytime you have injury to a muscle, so imagine this, let's say your bicep muscle, and oh gosh, well, I don't have a whole lot of bicep muscle here, but you can use your imagination, right? If there were a bicep muscle here, and I could lift 100 pounds with that bicep, and then I made an incision into that muscle, did something underneath, and then sewed it back together. Well, it will heal, right? It will come back together, but I will have lost about 20% of the strength of that muscle. So instead of being able to lift 100 pounds, I'll now only be able to lift 80 pounds. So the same thing holds true with the uterine muscle, which is called the myometrium. After the C-section, it becomes damaged. It needs to heal. And the other thing is that the only preventable risk factor for severe preterm birth is a short interconceptual interval. So I would say a year is probably a good time. Some would tell you 9 months, and I think that's not an unreasonable choice, but less than that, I think is probably not a good idea. What tests should you do before that next transfer? I would strongly recommend that you do a saline sonogram, because really once a year, I want to know that the uterine cavity is normal. And after having the C-section, you can have some scar tissue inside. You can have a polyp, you can have a band of muscle, or a growth of some other tissue on the inside. So let's make sure that the place we're going to put that beautiful, perfect embryo is just as beautiful and perfect as the embryo. So saline sonogram or a hysteroscopy, but saline sonogram is easy because you can have it done any place that does imaging, really any place with an ultrasound, even in your own doctor's office, they can probably do that saline sonogram. So once a year. Let's see what we have here. Kirsten's asking, again, the ERA and the Emma and Alice. The Emma and the Alice test are tests that look at the uterine microbiome to see if there's any sort of infectious agent or chronic inflammatory agent on the inside. I do not recommend the ERA as a matter of routine. And to be honest, the Emma and the Alice, it sounds like an interesting thing. It sounds like it ought to be great, and you can tell all kinds of things, but it's not covered by insurance. And frankly, we can do a simple endometrial biopsy, and even your own gynecologist can do that. And that endometrial biopsy can be covered by your insurance, that looks for the presence of what are called plasma cells. Plasma cells are the marker for chronic inflammation, or for what we call chronic endometritis. So that's really what you're looking for, Kirsten. Is there chronic endometritis there that could have stood in the way? And yes, it's possible. People can get pregnant with chronic endometritis. It happens all the time. But certainly in the fertility population where we're counting every embryo and every embryo really counts, it's something we might want to know. But I think we can get that information a lot cheaper for you. And so an ERA Alice is, again, probably not something that I would routinely recommend. Franklin Dormius. So I'm having trouble reading the name. Nice to see it. Do we do a Tessie? If I'm saying that right, that comes from the coach, Coach Seals. Nice to see you this afternoon. Tessie is a procedure done in order to get sperm directly from the testicle. That is typically done by a fertility urologist. Such a urologist is on site at CNY Fertility in Syracuse here in Colorado Springs. We use an outside male fertility specialist for that who works very closely with us. So we can certainly help you find where to go from there. Jaka24 says, if you don't produce many eggs, would you ever recommend a Clomid and a letrozole protocol? So generally speaking, I would not use Clomid and letrozole together. To me, that doesn't make a lot of sense. They're really functioning by the same mechanism. Although they go about it in a slightly different way. I've never seen any evidence that suggests that the combination of those is particularly useful. So for folks with a diminished ovarian reserve, there are some specific protocols that we can use that very much can help us maximize what we're able to get from the ovaries. So it's not a one-size-fits-all approach, and I would encourage you to talk with us about that because there are some things that we can definitely do. Let's see, looks like Vernicia is here. What's the best protocol for older patients over 40? A lot of times in our CNY patients, we will use a mini dose protocol in folks who are over 40. And the mini dose is just a lower exposure to medication. It is not always the best choice, but it may be the best choice for you with age-related diminished ovarian reserve. Because the data shows us, the classic wisdom was that we wanted to take as much medication as we could get and dump it on the ovaries so that we could try to really convince the ovaries to make some eggs. But what the data shows is that when you use those high doses of medication, sometimes the ovaries don't know what they're supposed to do, and so they'll kind of shut down. They just won't give you very many eggs, or they may give you eggs, but ultimately when we use the lower dose of medication, and this is sort of like what they do in it's the European protocols, lower doses of medication, typically in diminished ovarian reserve can get you the same kind of outcomes just with a lower exposure to medication compared to those very high doses from before. So mini dose is certainly something to consider, Renisha. Let's see, Katie is asking, I got my embryo report. Holy cow, I'm like, am I reading this correctly? 25 day 5 frozen and 12 of them are 4 AAs. That's fantastic. That's really great. That's a wonderful result for you there. Is there a way to still differentiate which one is best for transfer? Well, so usually what happens in that scenario is that we'll talk to the embryologists and let them actually look at the images. And even though they are graded the same, they'll usually pick the best graded embryo because they're looking for, kind of the prettiest, because for lack of a better reason, it's just, a way to kind of sort them out. But I would ask the embryologist to actually take a look at the pictures of the embryos and help you to select. But gosh, Katie, that is fantastic. My goodness, what an outcome. Hi to everybody who has joined. So it looks like Kaya Lene, nice to see you again, is asking, guys, please forgive me if I'm mispronouncing your handle there. I'm 40. I just unfortunately had an unsuccessful transfer. There's only one euploid embryo left. Do you recommend having the Receptiva test done? Now, I think Receptiva is a very good test. You can talk to other people. Dr. Kiltz, for instance, says, it's a ridiculous test. Nobody should do that. Everybody needs a laparoscopy. Well, we can all differ in our opinions, but Receptiva is a non-invasive test for endometriosis. And endometriosis can stand in the way of an embryo implanting. So one euploid gives you a 60% probability of being able to get pregnant. So it's not 100%. I typically don't start looking towards doing extra testing unless we have had 2 unsuccessful transfers. Now, by the time you have that second unsuccessful transfer, you say, oh man, I knew I should have done all this testing beforehand. There's not great evidence that shows us that doing testing before you know it's going to be a problem is particularly helpful. So it's easy for me to say it's not. I would certainly want to know that your uterine cavity is normal. Have you done a hysteroscopy? Have you done a saline sonogram? 100% I would do that. And I would be on the embryo transfer protocol supplement list, which I'm happy to send to you. But I wouldn't necessarily jump right into the Receptiva after that single unsuccessful transfer. Oh, let's see. We're going to have to wrap it up here pretty shortly. If we've got something else here, the earliest looks like Tula 33 called to schedule an appointment. The earliest I could get in is August. Holy cow. Wow, man, that is a long time. We will certainly do everything we can to try to get you in sooner. I just got 2 texts today from folks that we're going to try to see if we can expedite on. So if we can help you with that, we certainly will. There's only so many hours, we have in the day. So if it takes a little time to get to you, I hope that you will forgive us for that, but we will absolutely give you the very same care that we're able to give to everyone. And we'll do everything we can. There's also a cancellation list. And most of the time that cancellation list does move up. So my suspicion, my friend, is that you will be talking to us before August. Oh, well, let's see if I have time for one more. Yeah, Katie, with 52 retrieved, that's really something. Let's see what we have here. Yeah, going back to the talk about the HSG, I have a high pain tolerance. This comes from Maya, and it was brutal. They now want to do it under anesthesia. Well, one of the things that we're working on trying to convince Dr. Kiltz to allow us to do here is to do nitrous oxide or laughing gas when we do our HSGs. I agree that it's very painful. You know what you could do? You could help. You could send him an email, send him a text, send him something, say, please get nitrous oxide for HSGs. It's very easy. It's not expensive. And I think it makes something a lot more tolerable that can actually be pretty uncomfortable. Let's see, how many drops of the liquid vitamin D and K do I recommend? That comes from BJ Pumping. So, yep. Oh, and Amber Ben says, gosh, Amber, I'm putting you on the payroll, my friend. 5 drops per day in the one that I recommend, which comes from a company called Orthomolecular. In that liquid vitamin D, basically what you're doing is that you're getting 5,000 units a day if you're doing 5 drops, because it's about 1,000 units per drop. So you want to look at the serving size on that container. I talked to a patient yesterday who was using a different brand, and we sorted it out that she had to use, she was just using 1 drop per day because hers was significantly more concentrated, which means that there was a lot more vitamin D in every drop. So 5,000 units a day if you're taking D3 with K2 really maximizes your absorption of the vitamin D. And the nice thing again about that vitamin K that goes in with it, so they've known for a long time that vitamin K increases the absorption of vitamin D, and it helps with some calcium metabolism things. But there was a big study that was called the Rotterdam trial, and they looked to see, well, what does that vitamin K do in the vitamin D? It decreased plaques in the coronary arteries by 50%, and it decreased cardiac death by 50%, which is probably the most exciting news in cardiology I've heard in a long time. So the day I read that was the day I started using it, and I certainly recommend it for everybody who needs vitamin D. I'm happy to send you the link for that as well. Well, folks, it looks like we're going to have to wrap it up here, unfortunately. I sure do appreciate you spending your hour with me like every Tuesday afternoon at 4 o'clock in the mountains. It's Fertility with Fink and Friends live from Colorado Springs. If you're in South Florida, think about the Miami Center of Excellence and CNY Fertility's operation there for your monitoring. And if we can help you in any way, please reach out to us. Remember, infertility is not your book, my friend. It is just a chapter in your life. And we are doing everything we can to work with you to rewrite that chapter. So until next time, God bless everybody, and we'll look forward to seeing you again. Good night.